we're really going to hone in on one or two, mothers and children, populations that are very, very unique in these situations. I would like to welcome our panelists. Now I have to use the glasses. I'm in that age group. I'd like to welcome our panelists, and we have with us Peju Jaiyeoba, who is with Mother's Delivery Kits. We have Anita Sharma from the UN Foundation and Carolyn Maposhere from White Ribbon Alliance. I want us to stop for a minute and think about women and children. My own family was very much affected by a refugee situation. My mother is Vietnamese, and my uncle was, in 1975, one of those Vietnamese prisoners of war who was shipped to Guam. This irrevocably affected our family. While he was not a mother or a child, it affected everyone around us, including his own children. At the time, they called refugees evacuees, or my favorite, parolees, which was completely shocking and quite stigmatizing, actually. So let's think about not only the extended families of these refugees, but of the refugees themselves. These women are giving birth in the desert between Syria and Jordan. They are giving birth in underpasses in Budapest while they wait for the train. Women are giving birth in camps and in tents. And the Washington Post recently had an expose on some of these women. And one of the women said, "Our tent fell on us during a storm. I picked up my newborn and my other children in my arms, and I ran into other places to hide, other tents." So what is the most fragile day of your life? Do you know? The day that you are most likely to die. It's the day of your birth. These women are giving birth the most fragile day of their newborn's life in untenable circumstances. So that's what we're here to talk about. So I would like to start with Carolyn, and I would love for you to paint a picture of what, I'm actually going to ask all three of you this, to paint a picture of what it's like for a mother or a child in a fragile or conflict-affected setting. And so we're not just talking about refugees, we can extend to also fragile and conflict-affected states.
Hello, everybody. That's a picture where, wherever resources are hard to come by, the ones who suffer most are mothers and children, most vulnerable. They won't have enough food. Therefore, this mother is malnourished, this mother is stressed, and so is her child or unborn child. So they are malnourished. And when you go into labor as a malnourished mother, you are likely to bleed more. You are likely to have a complicated delivery. You are likely not able to breastfeed properly. It's a grim picture. And she may not even just worry about this child that she has. Other reproductive health services may not be available. I may not have family planning. Therefore, I will have another child too soon. And therefore, that's not a healthy situation. And that's a grim picture.
Carolyn, I think you're a midwife, right?
Yes, I am a midwife.
So you are speaking from your heart and from life.
I'm a mother as well.
Maybe even more from your heart. Yes.
And you also have this mother who does not make a lot of decisions. She's not in a position to decide a lot of things, like when to seek for health and what quality of health care should she seek for. She's a woman who has all the factors that normally lead to maternal death and child in death, all these factors surrounding her. That's a grim picture, in short.
No support. Peju, how about you? What do you see out there?
So I'm just going to ask everyone to take a moment and imagine a situation where you give birth on a bare floor Imagine a situation where the midwife would have to use her mouth to suck out mucus from the nostrils of newborn to prevent asphyxia. Imagine a situation where the birth attendant would have to sever umbilical cords with rusty blades or broken glass, risking or exposing the baby to neonatal tetanus. Imagine a situation where you're unable to reach your doctor, your midwife, your birth attendant because telecommunication facilities have been shut down in your location. Imagine those situations. Imagine the risk that mothers and babies face in those situations. Imagine how helpless they are. Imagine a woman, after giving birth, being asked to sit on a high chair and close her legs while bleeding to stop postpartum hemorrhage. Imagine all those situations simply because she's in a conflict zone, simply because she's in a conflicted area or a zone that cannot be reached. Those are the type of situations women and children in conflict or risky areas face. So just take a moment and imagine.
So Anita, you can either paint a picture or you can talk about what works. We have two beautiful pictures here, and I know that you've worked in many countries in the world.
Yeah, thank you, Joy, and thank you, everyone. It's a real pleasure to be here. Yes, Carolyn and Joy, you have painted such a vivid and grim picture about the challenges that women, children, adolescents in particular, that mothers and newborns face in those very critical hours of birth. I would say, as we're looking now at the week ahead at the UN General Assembly, and especially at the Refugees and Migration Summit on the 19th and all of the issues that we're going to discuss around global health, I think it is so critical that we focus on the Leave No One Behind agenda and really understand, in fact, that inequalities are on the rise. Whether they are in countries themselves that are undergoing fragile situations or in between cities. It depends so much who you are and where you live, the type of services that you receive. There's a new study that's just out now by The Lancet on maternal health, and it actually says that Black women in New York City are more likely to die of complications during childbirth than in Vietnam or North Korea. And that, to me, was, when I read the report findings that came out just this morning, really gave me pause, but I guess in some cases, no surprise. I mean, women are not facing those same dire situations that you mentioned, but they are very much still unlikely and to either have the services before they're, as they're pregnant or giving birth. So just to draw people's attention to it. But getting to, and I don't want to speak too long, but getting to some of the solutions, I work on an issue called Every Woman, Every Child, and it's putting into action the global strategy for women, children's, and adolescents' health. We're going to be talking about it a lot through the week at the UN General Assembly, and I would say we're trying to have a new focus looking at settings and those fragile settings that Joy was mentioning at the outset. Really, how do we, as actors in the development and humanitarian space, come together to ensure that because a woman is pregnant one day in a country and the next it's undergoing a fragile situation, that she gets the coverage and services that she so rightly deserves.
So I'm going to come back to that in a minute and ask for some very specifics about what we can do in that space. So Peju is an attorney. So what on earth is an attorney doing working in the space of women and children, and what did she come up with as a solution?
So yes, I'm originally trained as a lawyer in Nigeria, but I think my turning point was in 2011 when I lost a close friend at childbirth, and it was a death that put a face behind statistics for me. So I see 1 in 13 women, are at risk of dying at childbirth in Nigeria. And if you don't have a personal connection, if you don't know someone who knows someone who has died at childbirth, they're just numbers to you. You flip on to the next station. But when you know that one person, who was the 13, who was the 1 in 13 in a particular year, it's no longer statistics. There are now real people behind those numbers because you know them. You feel a deep connection to those kind of situations. And that's exactly my story. My friend died. She had the whole world ahead of her. She had big dreams, aspirations like we all do. And then everything died because she tried to give life. And it really shouldn't be happening now. It shouldn't be happening in the 20s, the 2000s, and the millenniums. It shouldn't really be happening. But that was what made the change for me. And that's how I started my foundation, training birth attendants across rural communities. And then I discovered that far above training birth attendants, you also need to provide sterile supplies, because of the risk of accessing sterile supplies in many settings and situations. And that's when we came up with the Mother's Delivery Kit, containing sterile supplies that women use at childbirth in many rural communities across Nigeria.
Wow. So if you don't have a solution, create one. So how about you? What is your story, Carolyn?
My story is I trained as a midwife. First, you have to train as a nurse 3 years, and then you train as a midwife. And then I decided to have a baby. I had my child. I had all the knowledge from my midwifery. I went to a gynecologist who told me, oh, Caroline, you are short. I'm 4'9". Small bony framework. Therefore, you're not going to have a normal delivery because your baby is, 3.5 kg, normal size baby. Therefore, you would need a C-section. However, in my culture, I have a mother-in-law. I have significant other people around me with all the knowledge that I have. These people tell me, and this is very cultural, every woman does that. You take herbs to widen the birth canal in preparation for your child, especially if you are a first mother, your first baby. You know what? With all the knowledge and information, I took the herbs, in spite of the knowledge that I should actually, not take that and just wait for my C-section. What I learned in that is you don't just educate the mother. You don't just give information. And health is not just a biomedical issue for most women in Africa. It's the poverty around it. It's the significant other people. It's the social beliefs, the religious beliefs, whose voice will be listened to. Therefore, through White Ribbon, what we have done is we have come up with a program on self-care, where we are empowering the woman with knowledge to identify risk factors that would lead to birth complications. But that's not enough. We said we should also involve the insignificant other people so that they also are informed and would help this woman to make the decision. Because what normally kills the woman and the child during childbirth is delayed decision to seek care, delayed care when they get to the facility. Therefore, if all these people are involved and if all these people also take part in the self-care and they are also educated, that would work. What I also learned is there are certain key people in society, like religious leaders, pastors, they are listened to. I then did a theology degree, became a pastor, so that I'm listened to when I'm talking about women's issues. You stand up as an activist, you want women's rights, you want these rights. They say, who are you? And if you now stand up and say, no, I'm a woman, I'm a mother, I'm also a theologian, people then begin to listen to you. And what also works is looking at a woman in total. It's not just, we have SDG 1, SDG 2. Women don't live their lives in compartments. We live life as life. Therefore, you need to be addressing the entire woman. You don't just take health as a health issue. Look at the rights as well. Look at the other issues, socio-cultural issues surrounding that. Otherwise, you will not achieve those goals.
Yes, I think that's a little also of what Peju was referring to. She went to solve one problem and discovered other problems that she needed to address. So Anita, you referenced some solutions. What have you heard, or what are your organizations doing that you find is working?
I'm going to talk on two levels. And first, to define when we talk about fragility, it can mean a humanitarian situation because of conflict or war, because of climate change, or because of contagion like Ebola or Zika. And on the two levels, there is the international community, and then the other level is at the local level. So what we have found, in any of those settings, it's women and children who are hurt first, worst, and helped last. And the work that we have been doing with and this is a little bit of jargon, so I apologize, within the development and humanitarian community is to ensure what you were just saying, that a woman that has the same needs whether she is in a fragile situation or an everyday situation. But in many cases, especially, we have been working to bring those communities together because in a situation of fragility, humanitarian actors might say, well, it's not really our responsibility to provide contraceptive services or to think about gender-based violence, which we know increases in those situations. We'll wait until the situation stabilizes and then we'll address it. But what we have said is that's not good enough. We really need to focus on getting those services to the women, to the children, and increasingly to young girls who are particularly vulnerable in these situations. Whether it's a young girl who has left her parents, gone to a camp, the parents potentially may want to marry her off because they think she'll be more secure there, and then potentially the challenges of pregnancy. So what we have been doing is trying to bring those communities together to get those services. The second level, what I would say, and this should come as a no-brainer and not a shocker when you listen to all of the work that Peju and Caroline are doing, but it's empowering the local communities who are there. They are the first responders. They are the ones on the ground. But then when we, as the international community, come in, we think we have all the solutions. We think we have all the answers. And potentially we have all the money, but that's not indeed the case. So what we have been trying to do is really show that communities need to be empowered. When you look at the Ebola response, the Zika response, it's you who are working there long before the international community comes and well after they leave. But it means more than just empowerment. It means getting the services and the resources into the hands, and that has been a bit of a challenge in terms of procuring those donor dollars. There have been, and you talk about solutions. There have been improvements at the World Humanitarian Summit in Istanbul. This in this past May that came out loud and clear. We'll be talking about it tomorrow in the Refugees and Migration Summit. So I think it is starting to happen, probably not enough or quickly enough, but there are solutions that are being proposed.
So solutions. Peju had a solution, and she somehow managed to scale this to 30 out of 36 Nigerian states, reaching 50,000 women. How many years did it take you to do that, Peju, and how did you do it? Because I think there are a lot of people who'd like to know the key.
So I would say that for me, a lot of things that worked, in respect of scaling my solutions in Nigeria to be able to reach more women, was actually in terms of capacity building and seed funding, which I all got from the United States government. So like you mentioned earlier, my background is in law and I'm in business. I understood at the point I was setting out that I needed background knowledge in business. I needed some kind of exposure in terms of global health working experience. I needed seed funding for my business. And I got the 3 of them from the United States government under the Young African Leaders Initiative program of the US government. So I got business training from the University of Texas at Austin. I got global working experience from the UN Foundation, Mama Team. And then I got seed funding from the United States African Development Foundation. Now, before the seed funding, I had sold only 6,000 kits. And then I had the seed funding for a period of 6 months, and were able to reach 41,000 women in the 6 months period. And then we started off this year with the goal of expanding the content of the kit to be able to cater for more situations. We introduced some other things in the kit, like misoprostol against oxytocin, which cannot be stored in many rural communities in Nigeria due to electricity and refrigeration problems, and some other things in the kit. And that is when our sales increased, and right now we are on 97,000 sales in Nigeria. So a lot of things has to do with investing in people. A lot of things also has to do with providing simple life-saving solutions, not big constructions. Simple life-saving solutions because they can be owned by the community. The community can feel that they are a part of this solution, and the solution can actually progress and carry on without you being in the community. So it is self-sustaining, self-building, emancipating for the people in the community.
So I think what you didn't mention, that funding didn't fall out of the sky. I mean, you must have worked hard for that. So congratulations, because I think you must have really been telling this story. So Carolyn, we're getting close to the end, and you are packing a lot of energy in that 4'9", and I want to hear a little bit about how you have helped women to find their voice, women and girls? Because you did allude to that earlier about empowering them by helping them find their voice.
Through support from White Ribbon Alliance, what I also think works is citizen-led accountability. The women know what's happening to them. They know most where it itches. Therefore, prescribing programs for them, that would not be addressing, scratching where it itches. Therefore, we actually did focus group discussions with women, asking them their experiences, and so that we could, when we want to offer respectful maternity care, we have to ask the woman, what do you think is respectful maternity care to you? Then they told us their experiences of delivering on the floor, experiences of having to be asked to bring some water, the health facility, being asked to clean up the linen that they have soiled during childbirth. They recounted experiences of being referred to a central hospital. For them, that was punishment. And yet, there wasn't enough communication between the midwife and the woman. So when we learned of all these things, then we can use this for training midwives. We can use this for advocacy to the local authorities and to government to address all those issues, to start to say, no more commitments. We now want action. Translate all those signatures and commitments that happen at UN to resource allocation. Translate it to action so that women don't have to deliver on the floor, so that women don't have to die while giving life.
Okay, we're at the end. We have your 30-second wrap-up for each of you. The one thing, nobody here is a journalist on this panel, and we're really counting on you guys to raise the voice for women and children in these situations. So your 30-second wrap-up, what do you want them to tweet, Anita?
That's great. For me, it's just looking this week and seeing where the priorities are for women, children's, and adolescents' health is inside the SDGs, and very particularly with the Refugees and Migration Summit. If we are truly going to leave no one behind, we have to reach the farthest behind first. And unfortunately, in many cases, that's women and children. So that would be my plea to you. And if you want more information, everywomaneverychild.org, we have our work stream on everywhere where we're trying to address those particular issues. So thanks for the plug.
So here's what I want out there. The location of a woman, as well as her economic status in life, should never be an excuse to let her die. Let everybody know that today.
Citizen-led accountability. Ask the women themselves, what is it that they want? The second thing that I would like to see happening is us not just talking about the woman and the child. You're looking at me as this conduit that is just delivering. Look at my sexual rights as well. What do I really want? How do I enjoy sex? Let's add this S to the reproductive health so that it's sexual and reproductive health.